Good afternoon, everyone. I'm Shanika from University of Sydney and a past graduate from Kyoto University, originally from Sri Lanka. And today I'm going to talk something interesting for the public health researchers, one emerging public health issue. Not actually emerging, in most of the countries it is lasting for a long time now. For some countries it's an emerging public health issue. It's chronic kidney disease. Particularly, I'm going to focus about chronic kidney disease of uncertain or unknown etiology. Some background about chronic kidney disease. In definition, chronic kidney disease is renal insufficiency based on renal tissue damage or estimated glomerular filtration rate lasting for over 3 months. When we look at prevalence data globally, we can see it has been already identified as a public health issue because of increasing number of patients diagnosed. And median global prevalence published is 7.2 in more than 30 years age group. But when it comes to the aged population of 64 years, it can range from 23.8 to 35.8. It's quite high. The major reason is the health care needs for these patients are quite costly. When it comes to the low and middle social income group countries, like Sri Lanka, and I know in Taiwan it's a problem, and India, we are faced with a very big issue because we don't have enough facilities, even though it's identified as a social right for them to have the health care. We don't have enough facilities to cope with this higher number. So, in Sri Lanka, it is one of the most important non-communicable disease at the moment, where the Ministry of Health is trying to provide more facilities to the affected population to take care of them. Regarding healthcare in Sri Lanka, it's different from all what I heard from the morning. It is free of charge. Public health system is completely free of charge, and we don't have health insurance system. We have private health sector, but mostly located in the major cities, not in the regional areas. Now, regarding the etiological factors of CKD, we know that aged population is one of the major reasons. But increasing prevalence in diabetes and hypertension has caused a larger number of CKD patients as a complication. Hereditary causes or genetic factors have been published recently. They have identified several genes that can be predisposing to chronic kidney disease. And environmental factors, including heavy metals like cadmium and arsenic, have been reported in some of the countries. And some of the countries, they have reported about involvement of agrochemicals, mycotoxins in pathogenesis of chronic kidney disease. In addition, there are so many other factors like infections, urinary tract obstruction, drug-induced, most commonly non-steroid inflammatory drugs. But in Sri Lanka, we have a group where we can't find the etiology. They don't have any identifiable etiology for this chronic kidney insufficiency. Not only in Sri Lanka, if we see the prevalence information, we don't have the actual data, but we can see Mexico and Central American countries, in the sugarcane farming community, it's a common problem now. And in Egypt and India, especially southern Indian populations, they have reported of the higher prevalence of chronic kidney disease of uncertain or unknown etiology. Unfortunately, we don't have actual prevalence data for Sri Lanka. One recent report from WHO, they conducted a screening program. They mentioned 15.3 to 20.6, but they have not completed the screening in all regional areas. But in clinical data or the hospital data, they mentioned this is one of the major causes of mortality in the hospitals, especially in North Central region in the country. You can see this part. When we check the etiology of chronic kidney disease in other parts of the country, like Colombo, Kandy, the cities, etiology is quite similar to the other countries, like major problems are diabetes or hypertension. But in this area, these patients, they don't have these factors. And we can't find any possible etiological factors in these patients when they come to the hospital. But only thing what we know is the disease progresses very rapidly and they die. So the hospital mortality data is quite high, and this region, this is the most dominant cause for hospital mortality. Regarding the population, it is prevalent among the low socioeconomic paddy farming community in the dry zone. And regarding the onset of disease, they don't have symptoms until they reach the latter stages, CKD stage 4 and 5. That's the main issue, because when they're present, they need renal replacement therapy, dialysis or renal transplantation. And it's quite late for the diagnosis. That's the major problem on the healthcare system, because in this region, when I started the project, they didn't have any dialysis centers. Patient had to travel to Kandy or Colombo to get the dialysis. And for a low socioeconomic community, this is not practical. So unfortunately, most of the patients, they die even without accessing the treatment. But now, recently, this photo, the second one is from Anuradhapura, major regional hospital in North Central region. They have developed a new renal unit. So patients are getting better care than earlier. So it's one good thing. After publishing all this information, government has taken action to provide more facilities to the region. One major issue with male preponderance is males are the main working community in these farming areas. So once the male or the father of the family is affected, that's a social burden on the community. And the other thing is familial clustering. During our field visits, we found several families, all the males were affected. So all burden of the family burden are on females. When we check the prevalence data available based on the hospital data, males have 2.5 times risk than the females to get the disease. So when you talk about CKD-U in Sri Lanka, as I mentioned, they don't have history of diabetes or long-standing hypertension. If you check the urine full report, no active sediments. Culture negative, no evidence on infections. Proteinuria is intermittent. They don't always have proteinuria in early stages. We couldn't find any immune complexes in their tissues, so we excluded the possibility of immune-mediated disease like IgA nephropathy. And they had normochromic nomocytic anemia as a complication, secondary complication. So when I joined Kyoto University as a PhD candidate, I was fortunate because my supervisor, Professor Akio Koizumi, gave me the opportunity to investigate on a health issue in my country. So as a clinician, I knew the gravity of this issue. So I really wanted to investigate. And we started a new CKD consortium. Our investigators were from Japan, Sri Lanka, and Australia. And regarding my role in the project, I initiated the project and established the consortium, and I got directly involved in study design, sample and data collection, and analysis. And after I joined the University of Sydney, still the collaboration work is going on. And I'm getting enough support from my collaborators, and recently University of Hokkaido Department of Microbiology joined the project to continue some microbiological investigations as well. So at the time of the start of the project, there were no evidence on pathological characteristics of the disease. There were no clear evidence on the etiological factors, but there were a lot of media reports suggesting different etiological factors like the possibility of involvement of cadmium, arsenic, fluoride, aluminum, and even mycotoxins. One epidemiological report, they suggested possibility of family history as a risk based on their survey. So what we wanted to do is, first we wanted to characterize the disease. We wanted to identify the pathological process in the disease and to identify any possible etiological factors. In addition, it was our responsibility to find an efficient screening method because we really wanted to identify the patients in early stages so we can prevent disease progressing to later stages where the renal replacement therapy is a necessity. So first we did pathological investigations. This is the gross pathological view of the kidney in late stage CKD-U patient. As you can see the surface is not that smooth as the usual kidney. It's very coarse and granular. And if you measure the size, it's smaller. It's a contracted kidney. We didn't see any infarcts in the cortex. Further staining, I have shown you slides from later stage kidney disease patient, but early stage we can see only focal fibrosis in the interstitium, tubular interstitium. But later fibrosis spreads over, and in later stage, in stage of renal failure, the whole kidney gets fibrosed and contracted. And sometimes it is accompanied with mononuclear cell infiltration. Next, we wanted to see whether there are any genetic variants involved in pathogenesis of this disease. First, we did some field visits to see whether there are any familial clustering. And yes, as the previous epidemiological survey reported, there was familial clustering. It was obvious. And we saw a lot of males who were affected. So we decided that we will do further genetic analysis using 2 sample areas which have high prevalence, Nanayakkara and Giranduru, this area. And our sampling period was from March to August in 2011. This is a study design. So regarding the CKD-U cases, we recruited cases, biopsy-proven, who were having tubular interstitial disease with all the information that I mentioned earlier, excluding the possible etiological factors. And they were from the same ethnicity, male patients within the age group of 20 to 70 years. Our response rate was 90%. Approximately 10% refused to participate in the study. For our controls, we wanted to collect a sample of controls to compare from the same community. So we invited apparently healthy male participants who were Sinhala, that means the same ethnic group, within the same age range, to participate. We had a response rate of about 60%, and we had filtering criteria to make sure they are healthy. So first criteria was the blood pressure. And it's interesting to see that during blood pressure measurement, we had to exclude 154 participants with high blood pressure undiagnosed in this region. And the next step was urinary proteinuria and glycosuria. Again, we excluded 24, and the patients didn't report any history, previous history. And then we checked the HbA1c level, eliminated again 17. And as the last one, we did serum creatinine level and alpha-1 microglobulin levels. And we ended up with 286 suitable cohort as the controls. With these 597 subjects, we did a genome-wide association study screening for over 500,000 SNPs. And interestingly found one genome-wide significant SNP in chromosome 20 located in SLC13A3 gene in the promoter region. Based on our QTL and dichotomous analysis, we did both, and we found it is significantly different when we compared with the controls. And the population attributable fraction was 50%. It was one very interesting finding for us in this study. During the functional analysis process, we found that this SNP has a protective function for this population. Regarding SLC13A3, this is located in basolateral membrane of human renal proximal tubules, liver, brain, and placenta. In previous report, they have mentioned that it is involved in diabetic nephropathy, hypertension, and renal fibrosis. But very limited evidence about this gene as well. Now, the major culprit was the environmental factors, whether there is any involvement of heavy metals, especially cadmium and arsenic, as the media report suggested. Okay. And some of the researchers gave some controversial evidence on possibility of cadmium and arsenic toxicity during the time we did our investigations. So we wanted to make sure whether it's present or not, because if it is present, it is very easy to prevent, rather than allowing them to get exposed further. So as our stage 2 of the study, we did analysis of drinking water, rice, and urine for heavy metals. Our sampling areas included Nanayakkara and Girandurukote, those highly prevalent areas. Nikavawa, it is one area that was free from disease but located in the same geographical region. And Kandy and Nuwara were away from the dry zone, they were in the wet zone. We took them as control areas as well. When we analyzed the metal levels in drinking water in the affected region, we clearly found that there is no possible toxicity with arsenic, contamination with arsenic and cadmium. Our levels were far below than the recommended levels from WHO. So drinking water was unlikely to be the contaminant or the reason for cadmium and arsenic toxicity if possible. To show you the data regarding cadmium, arsenic, and lead specifically, which are main nephrotoxic agents that have been reported. So in affected areas, you can see the levels are quite low. Because if it is contaminated in countries where the water is contaminated with these heavy metals, they have reported much higher values. Our values are within the recommended levels. So there was no evidence on contamination of drinking water. And we have done the study for groundwater and surface water as well. So if it is not drinking water, the next possibility is food, whether there is any possibility of exposure through food. And in Sri Lanka, the main food is rice. So regarding cadmium, we were suspicious whether rice is contaminated with cadmium, and of course for arsenic as well. So we measured the levels in rice as well from the affected region. Again, they were within the recommendations. We couldn't find high levels of arsenic or cadmium in rice. The results have been repeated 3 times with our collaborators repeated to further confirm, and everything was negative. And to compare the levels with the Codex guidelines, you can see cadmium, arsenic, and lead levels, we don't have any recommendation, but for cadmium and arsenic, the recommended levels were much higher than the observed levels in Sri Lanka. So with this evidence, we reported that there is no possibility of drinking water contamination or rice contamination that can be a possible risk factor for CKDU in Sri Lanka. We wanted to further confirm. So we did urine analysis as well. We did the urine analysis in both patients and controls, whether there is high urinary levels of cadmium and arsenic, other heavy metals as well. Interestingly, we found the levels were higher in the controls. Regarding arsenic, because arsenic level in the control were slightly higher than the levels reported in some of the countries in healthy populations, we did the arsenic speciation to see whether this arsenic is actually the toxic form or not. But what we observed was around 70% of the arsenic in urine is acinobutane, that is the non-toxic form. So we could again exclude the possibility of arsenic and cadmium in involvement in pathogenesis of CKDU. Last one, for hair also, because if the subjects are exposed to arsenic, they have the hair contamination. the arsenic can be detected in their hair samples. We did hair analysis in cases controlled from CKD region and non-CKD region, and we found that they were below the recommended levels, and the patients have very low arsenic concentration in their hair. Confirmed with electron microscopy, there was no disformation mitochondria or metallothiones supporting heavy metal toxicity in our proximal tubular cells. Drinking water analysis, again, it was negative. Fluoride levels were within recommendations, and serum analysis showed the patients who were not affected, or early stages, have normal fluoride level in serum. But as disease progresses, we can see higher fluoride levels, mainly because of renal insufficiency. Fluoride accumulates. We did screening for mycotoxin, aflatoxin, ochratoxin, and fumonisin. They were within the comparable levels with the other healthy general population around the world. Recently, our collaborators from Hokkaido University have done screening on hantavirus infection. The reason for this is they did a screening on hantavirus infection in another community in Sri Lanka, mainly focusing the patients with similar symptoms like leptospirosis. And they found hantavirus prevalence is higher than expected in this population. So they compared our cases and controls, and they found there was higher serological evidence among cases. And so this part is still continuing. So they wanted to further investigate to make sure whether this is really involved in the pathogenesis of the disease. As I mentioned, we really wanted to find a diagnostic marker. So we compared alpha-1 microglobulin and NEG to see whether it's an efficient screening marker to detect the early stage chronic kidney disease of uncertain etiology. We selected the cases from Madawachi and Girandurukote, controls from Madawachi, Girandurukote controls, and from Japan as well. When we see how the alpha-1 microglobulin level varies in urine, we can see there's a clear relationship with the CKD stage. But still, we can see this can't diagnose all the patients in early stages, so healthy people, only using alpha-1 microglobulin. So what we are doing at the moment is we combine alpha-1 microglobulin, serum creatinine, and proteinuria, 3 markers together to screen the population. That's what the Sri Lankan collaborators are doing at the moment. So regarding the disease characterization, we reported that the most dominant histopathological observation was tubular interstitial fibrosis in CKD-U. We couldn't find a single specific genetic or environmental factor responsible for disease pathogenesis, suggesting a multifactorial disease. And SLC13A3 is involved in pathogenesis of CKD-U, and it has a protective effect. There was no evidence on heavy metal, especially cadmium and arsenic, in involvement in pathogenesis of CKD or even fluoride. But still, we can't exclude the possibility of involvement of hantavirus infection. And there was no evidence of aflatoxin, ochratoxin, and fumonisin in the involvement in pathogenesis of CKD-U. And finally, regarding diagnostic markers, we suggested the possibility of including alpha-1 microglobulin to further improve the efficiency of screening programs. And most importantly, what we observed was prevalence of undiagnosed non-communicable diseases were quite high, roughly around 40% in the population that we screened. So we have passed this information to Ministry of Health, suggesting them to include the preventive and screening measures and to improve the health facilities for this population. And some of our suggestions have been accepted. And at the moment, with the funding support from the Ministry of Health in Sri Lanka, our Sri Lankan collaborators are screening the population. And they have screened several pockets to find out the patients in early stages and to refer them to the necessary care to prevent them going for the late stage diseases. And in 2014, the government established several satellite dialysis clinics to support these patients in this affected region. And I have to acknowledge this organizing committee and Kyoto University for providing this opportunity for me to come and present these findings. And to our CKD consortium, my supervisor, Professor Akio Koizumi, and my lab mates. and my Sri Lankan health staff who helped me with sampling and field works, and of course to all the subjects who involved in this study. Thank you very much.